Hey my friends, welcome back to the channel. Today, we are tackling a topic that is absolutely critical for every single one of you, whether you're a med student, a resident or practicing physician. We are diving deep into the world of community-acquired pneumonia, or CAP. Now, I'm not just going to throw a bunch of drugs at you. We are going to build a fortress of knowledge. We're going to break it down by where the patient is, in the clinic, on the hospital floor, or fighting for their life in the ICU. By the end of this lecture, you are going to be the expert your friends, your colleagues, and your patients call when they're scared and short of breath. You ready? Before we dive right into it, if you find this video helpful, hit the like button, comment in comment section, and please subscribe. Let's get it. First up, our outpatient management. This is the front line. The patient walks into your clinic. They're coughing, they have a fever, but they're stable. They can go home. But we have to be smart. Our first job is to ask one critical question: have you taken any antibiotics in the last 3 months? Because, my friends, we are in a war against antibiotic resistance. Now, let's split this into two groups. Scenario A: the patient is previously healthy. No chronic diseases. And they haven't touched an antibiotic in the last 3 months. These are the easy ones. We have two fantastic options. Option 1. We hit them with a macrolide. Now, what's our go-to macrolide? We have two all-stars. Clarithromycin, 500 mg by mouth, twice a day. Azithromycin, we call this the Z-POC. The classic dosing: 500 mg is a first dose, then 250 mg once daily for 4 more days. Or, for simplicity, 500 mg once daily for 3 days. Option 2, doxycycline. This is a workhorse. We give it 100 mg by mouth, twice a day. That's it for the healthy group. Simple, right? But hold on. What if the patient is not so healthy? Scenario B. This patient has comorbidities. We're talking chronic heart, lung, liver, kidney disease, diabetes, alcoholism, cancer, asplenia, meaning no spleen. Or they are immunocompromised, either from a condition or from drugs like steroids or chemotherapy. Or, and this is a big or, they took antibiotics in the last 3 months. If any of these are true, we need to escalate. We can't just use a simple macrolide. Our resistance rates are too high. Here are our two strategies. Strategy 1. Use a respiratory fluoroquinolone. These are our heavy hitters. We have 3 main ones. Moxifloxacin, 400 mg once a day. Gemafloxacin, 320 mg once a day. Levofloxacin, 750 mg once a day. Strategy 2. This is a combination. We use a macrolide like azithromycin plus a beta-lactam. And not just any beta-lactam. We want the good stuff. For oral therapy, our preferred ones are amoxicillin 1 gram, 3 times a day, or amoxicillin clavulanate 2 grams, twice a day. We can use cefpodoxime or cefuroxime, but the amoxicillins are our top picks. Now, here's a pro tip. In some regions of the world, the bad bug, Streptococcus pneumoniae, has become highly resistant to macrolides. If the rate of that resistance in your area is over 25%, then for these sicker outpatients, you should just skip the macrolide combo and go straight to the fluoroquinolone in strategy 1. Okay, outpatient done. Let's move to the next level. The inpatient non-ICU. Now, this patient is sicker. They need to be admitted to the hospital. But they're not sick enough for the ICU. They're on the medical floor. They're stable, but we need IV antibiotics. Our goal here is the same: cover the bugs, but with more firepower. We have 2 main, equally good strategies for these non-ICU inpatients. Strategy 1. We go with a respiratory fluoroquinolone. Orally, we use the same ones we just mentioned: Moxi, Gemi, Levo. But now, we can also give them intravenously. So, we can give moxifloxacin 400 mg IV daily, levofloxacin 750 mg IV daily, or, and this one is important for some specific bugs, ciprofloxacin 400 mg IV every 8 to 12 hours. Strategy 2. This is our combination therapy again, a macrolide plus a beta-lactam. Orally, We use the same drugs from before. But IV. Now we're talking. Our beta-lactams are ampicillin, 1 to 2 grams every 4 to 6 hours. Cefotaxime, 1 to 2 grams every 4 to 12 hours. Ceftriaxone, the classic, 1 to 2 grams every 12 to 24 hours. Alright, we're doing great. But now we come to the highest level. This is where we separate the casuals from the true master. The ICU. The intensive care unit. The patient is critically ill. Maybe they're on a ventilator, maybe their blood pressure is crashing. Time is tissue. We need to cover everything, and we need to do it now. Our foundational principle in the ICU is a combination therapy. We use 2 drugs to make sure we don't miss anything. The backbone is an antipneumococcal beta-lactam. That means a beta-lactam that is excellent at killing Streptococcus pneumoniae, the most common cause of CAP. Our go-to IV drugs here are cefotaxime, ceftriaxone, or ampicillin sulbactam, 1.5 to 3 grams every 6 hours. We then pair this backbone with either azithromycin, the same Z-POC dosing we talked about, or a respiratory fluoroquinolone. Now, what if the patient is allergic to beta-lactams? We can't use that backbone. So what do? We pivot. We use a fluoroquinolone like levofloxacin plus a drug called aztreonam, 1 to 2 grams IV every 6 to 12 hours. Aztreonam is a special beta-lactam that is safe for patients with most penicillin. But wait, we're not done. The ICU is where we have to think about other nasty bugs. We have to ask ourselves 2 more questions. Question 1. Is this patient at risk for Pseudomonas infection? Who is at risk? Think about structural lung disease like cystic fibrosis or bronchiectasis. Or patients who are severely malnourished, or on long-term steroids. If Pseudomonas is on the table, we have to change our beta-lactam to an antipneumococcal, antipseudomonal beta-lactam. This is a very specific class. We're talking piperacillin tazobactam, 3.375 to 4.5 grams every 6 hours. Cefepime, 1 to 2 grams twice a day. Imipenem or meropenem, carbapenems. Now, we pair that heavy-duty beta-lactam with one of 2 options. Option A. Pair it with ciprofloxacin or levofloxacin. Option B. Pair it with an aminoglycoside like gentamicin or tobramycin. These are weight-based and we have to monitor drug levels in the blood plus either azithromycin or a respiratory fluoroquinolone. Question 2. Is this patient at risk for methicillin-resistant Staphylococcus aureus, or MRSA? This is a huge one. Who is at risk? Think about patients who live in long-term care facilities, who have had recent hospitalizations, who have wounds, or who inject drugs. If MRSA is a concern, you add 1 more drug to your already robust regimen. You don't replace anything. You add coverage. Our options are vancomycin. We dose this based on kidney function and we aim for a trough level, the lowest level of drug in the blood before the next dose, of 15 to 20 mcg per milliliter. This is a very narrow window. Linezolid, 600 milligrams twice a day. You, my friends, now have the roadmap. When you see that patient with a fever and a cough, you won't panic. You'll know exactly what to do, whether they're in a clinic, on a ward, or in the ICU. I want you to take this knowledge, apply it, and become the incredible clinician you are meant to be. Smash that like button if this helped you conquer CAP. Subscribe and hit the bell so you don't miss our next deep dive. Share this with your study group, your colleagues, anyone who needs this clarity. Until next time, stay sharp, and stay healthy. Peace.